Welcome everybody to this webinar in the Emerging Issues in Medicine series from the Association of Physicians. I'm Colin Dayan. I'm a clinical diabetologist and Professor of Clinical Diabetes and Metabolism in Cardiff University, and I'm the Treasurer of the Association of Physicians. And my co-host today is going to be Paul Harper. I'm going to pass over to him in a moment, and then we'll have three speakers who will outline the topic that we have today, which is our question, machine learning and artificial intelligence in medicine, for now or for tomorrow. And the aim is that we'll have brief presentations from our three expert speakers and then have a panel discussion. I point out that you can enter your questions in the chat. We've already had some questions ahead of time. We'll try and deal with as many of those as we can to have a lively discussion between our experts. Over to you, Paul.
Great, thanks, Colin. Good afternoon, everyone. My name is Paul Harper. I'm a Professor of Operational Research in the School of Mathematics at Cardiff University. My own particular interests are in data science and analytics applied to health services. I'm delighted that we have the three speakers, as Colin said, this afternoon. So I'd like to introduce our first speaker, Tom Monks. Tom is an Associate Professor of Data Science within the College of Medicine and Health at University of Exeter. Tom and I have worked together on lots of different projects, and he's a Turing Fellow at the Alan Turing Institute, where his research focuses on machine learning applied to health services. So Tom's going to give us a short introductory talk about what is AI and machine learning. So over to you, Tom. Thanks very much.
Thanks, Paul. I'll just share my desktop. So hopefully there'll be a few nodding heads that you can see my screen. Good. Okay, so let's first talk about the elephant in the room, AI, and what we mean by AI. So it's actually not that much of a helpful phrase, actually, because AI is such a big topic, and it extends even to the extent of, these robots we see in movies having human level intelligence and being able to do all sorts of tasks. And that's just not the case in medicine now or for the foreseeable future. So in medicine, we're really interested in a subset of machine learning, of AI, called machine learning. And that's a very narrow type of intelligence. And it's training algorithms to perform very specific tasks. And it will perform those tasks to a level of performance that may be similar to and better than some humans, and may even be as good as experts within the field. So let's have a look at where AI, so machine learning, has shone really in recent years, which is with images. So let's take a non-controversial topic outside of medicine to start off with. So imagine you needed a computer to recognize, to classify if an image is a dog or if an image is a cat. So in a traditional paradigm, you would write down the rules of that algorithm. So what do you need to take into account to determine if an image is a picture of a dog or a cat? So you might think about the size of the animal, the shape of its nose, the length of its ears relative to its legs. But what about if the image is upside down, or if the dog is sitting down, or if it's just a picture of a grumpy cat's face? So it turns out that writing this list of instructions is extremely difficult to do. It may be possible to get something down, but actually any algorithm you produce like this won't be very accurate. So now let's think about a different type of image. So what about if we wanted to diagnose if cells taken from a breast contain a benign tumor or malignant? So this is data taken from a real study done back in the 90s, a famous study, the Wisconsin breast cancer dataset, which is available online. And that was very simple data, really. So we had a malignant or benign tumor. And instead of using the raw image, what the authors did was they processed the data, they featurized it into a set of tabular variables. And it was a long list of variables. But the same problem applies if you want to use a traditional artificial intelligence approach for modeling this. You'd have to write down a list of rules that your algorithm would need to take into account. And this is very hard. And again, you can bring experts in to have a go at this, but it's very difficult. So that traditional paradigm looks like this. So we come up with our rules ahead of time, and we take those with our data and we feed those into a model, a program, and that produces our predictions, our answers for us. Machine learning flips that axis on its head. So instead, we label all of our data in advance. So we have all the answers to our data, and we pass both those answers and the data to a machine learning algorithm, and it trains, it learns from that data, and that infers the rules within the data. Now, you should recognize this from biostatistics. And in fact, when you look at the medical literature, this is the dominant sort of machine learning approach or style of machine learning study that you will see, but it's not the full story. So just to recap, what we've talked about is what's called supervised learning, and that is a subset of machine learning itself. So we take our data, our images, perhaps of cats or dogs, or of benign and malignant tumors, and we label that data. There's an expense involved. Somebody, probably an expert, has to label that data. We then pass that data to a machine learning algorithm, and that trains a model. Now, what that training looks like will vary dramatically depending on what type of model you're using. And it includes statistical learning that you would see in traditional biostatistics. Strong stuff that we know works, such as logistic regression, would be included in that. But it can go all the way up to something complex like a neural network model. And for images, that tends to be the methodology that's used. So at the end of this training, and I'm sweeping a whole bunch of stuff under the carpet here, but at the end of this training, we have a model that we can use, that we can then pass unlabeled data to. So new unseen instances. And we get a prediction of some description. And that might be, for example, class membership. Is this a cat or this a dog? Is it a malignant or benign tumor? And more than likely, that will be a statement of probability of falling within those classes, as well as some measure of how confident the model is that it's got it right. So I'll wrap up here, but I just wanted to say that the machine learning landscape is big. So AI is big and machine learning is big as well. And what I've got here is just some of the styles of study you'll see in the academic literature for medicine. So I think the most common type of study you will see is a supervised learning study. So that's where we've got labeled data. Someone's spent some money to label the type of data we've got. And it can be classification, like I've talked about, but it can also be regression. So we have a continuous variable, a quantitative variable that we're trying to predict. So for example, that could be the length of stay in a post-recovery ward following surgery, given some variables that a model was told about before the surgery actually happened. But the majority of data out there is unlabeled. And so that's where unsupervised learning comes in. So traditionally that's used for clustering data, for finding interesting groups of patients, for example, that are visiting your outpatient clinic, how they relate to each other and how they might differ from other groups, as well as any anomalies within that data. So then we get onto things which you are less likely to see in medicine. And that's sort of, with my list here, that gets less and less likely as we go down. So I won't go through those in detail, but these are names you should look out for. So semi-supervised learning, if you've got an Android phone like me, Google is using that all the time with your images. And it approaches the creepy line. So for example, they know who my children are, but they don't know who their names are. So they're mixing labeled and unlabeled data and filling in the blanks. And then we get down to the sort of topics that I'm interested in researching, which are kind of perhaps for the future and not for now, which is reinforcement learning, which is a very different beast from the supervised learning we've talked about. So in this, you have no data to start off with, but you do have a model of some description. So for example, I'm interested, like Paul, in healthcare systems. So we might have models of entire hospitals or emergency departments that an agent interacts with in order to learn how to manage them in different ways and take different limited actions. And then we have self-supervised learning, which again is one of these methods to try and get around this problem of it's really expensive to label data. You need experts to do that. So in that, we start to try and predict any part of our data from other parts of it. And that's really another method for the future. In fact, you won't see much of that literature around in any applied context at the moment. So that's probably the world's shortest overview of machine learning. And I must emphasize that I have swept a huge amount of detail under the carpet. It's worth taking away that all the rigor and the issues that you get in traditional biostatistics studies apply very much to machine learning as well. There's a few extra ones due to the volume of data you might be using, and the provenance of that data, and how that may lead to significant bias within your results as well. But I'll end there.
Great, thanks so much, Tom, for being concise but super informative. We'll take, as I said, Colin said at the start, we'll take a Q&A at the end after all three speakers. So if we now move on to Irena Spasic, who is a professor of computer science at Cardiff University. Together, Irena, we are co-directors of the Data Innovation Research Institute here at the university. And Irena's main focus is decision-making with big data for healthcare and particular expertise in text analysis. And Irena is also an elected fellow of the Learning Society of Wales. So Irena, over to you.
Thank you. Okay, can you see my screen?
Yes, we can, thanks.
So just to check, you're seeing not my notes, but you can see here, it's not the presenter view.
Yeah, just the presenter, yeah.
Yeah, okay. So thanks for the introduction and the invitation. I'll talk about text analysis. And to better understand the need for text analysis in healthcare, we should start by looking at the major stakeholders in the healthcare system. So at the center of this system, we have a patient, their carers, and the wider community. And they are directly engaged with the healthcare providers. The healthcare is remunerated through insurance, whether private or national, and the consistent quality and cost of healthcare provided is prescribed by the policymakers. And new types of treatments and diagnosis are enabled by research. And to support optimal decision-making, these stakeholders need to communicate. And such communication is by and large supported by a natural language. So patients and healthcare providers most often talk to one another, and information based on such conversation will be written down into a medical record. Information from policymakers, such as NICE guidelines, and from clinical researchers, such as inclusion and exclusion criteria for clinical trials, will also be in the form of written text. Dictated information will also ultimately be transcribed. And even when other types of data are used to capture information, they will also be described using natural language. So for example, when an X-ray is taken, a radiologist will write down a report. So therefore, written text will be the most common type of data found within healthcare. And natural language will remain a predominant means of information exchange among the stakeholders. Such information is easy to record, but not necessarily easy to access, especially on a large scale. So one problem with using natural language in healthcare is ambiguity. So for example, the word cold can be interpreted as cold temperature, common cold, or short form for chronic obstructive lung disease. And when analyzing text automatically, such ambiguities need to be resolved, as otherwise they could result in unintended consequences. So this is why clinical narratives are typically complemented by clinical codes. So for example, the NHS uses SNOMED, structured clinical terminology, designed for use in electronic health records. And SNOMED is integrated into the UMLS, together with around 150 other terminologies. And each concept has got a unique code, and these codes allow us to encode, for example, different meanings of the word cold, as you can see at the bottom of this slide. Traditionally, text mining applications such as CText map text onto the UMLS. And in this example, we can see that 3 UMLS concepts have been recognized: CT scan, lesion, and liver. They are associated with their unique concept identifier, but also their semantic type. So for example, we can see that a CT scan is a procedure, a lesion is a disease or disorder, and liver is part of anatomy. So this then enables text mining applications to reason about the meaning encoded in text. However, traditional NLP approaches, such as this one, have been plagued by the so-called out-of-vocabulary problem. If a word is not available in a dictionary, then the system does not know how to process it. And similarly, when machine learning is used, then any words that were not present in the training data cannot be readily utilized. And this problem stems from the discrete nature of word-sensed representation. If we take UMLS as an example, then we can see that words are mapped onto concept identifiers, which are underlined at the bottom of this slide. So in effect, sense is modeled as a categorical or qualitative variable, and it can only take a limited number of prefix values. We can view this as a process of mapping words onto discrete points in a given semantic representation space. And the problem here is that new words, for example, podcasts, that have no existing representation would fall through the cracks. And similarly, new meanings of existing words, such as the word cookie as a piece of data rather than a biscuit, would also fall through. So alternatively, we can explore representation of meaning as a point in continuous space, so that the new words can be positioned somewhere on this continuum relative to other words that share similar properties. And such an approach has been enabled by two important developments, including word embeddings and neural networks. And although these concepts are not new, several methodological and technical advancements enable these to shift NLP in a new direction. And the basic idea of distributional semantics proposed by Zelig-Harris is a distributional hypothesis, which states that words with similar distributions have similar meanings. Word embeddings, which take the form of real-valued vectors, are based on this idea, and they encode the meaning by concentrating words that occur in similar contexts close together. So based on distributional hypothesis, close words should be similar to one another. So for example, both cold and flu co-occur frequently with words such as fever, cough, sneeze, ill, etc. So their embeddings would be expected to be close in the vector space. And moreover, when the same word is used in different contexts, it can have different embeddings that reflect the current context. So for example, the embedding for the word cold used in a sentence such as "I feel very cold" would be distinct, and it would be close to other words such as chilly. And similarly, when it is used in a sentence such as "smoking is a major factor in cold exacerbations," its embedding is expected to be close to its synonym, which is COPD. So there are various methods that can be used to generate such embeddings automatically, but the most successful ones are based on neural networks. And as the basis for word embeddings is distributional hypothesis, for such distribution to be representative of the meaning, we need enormously large training data sets. And they're now available on the internet. So it's not surprising that companies such as Facebook and Google are actually the ones driving these developments. So where do we stand now with the out-of-vocabulary problem? As embeddings are based on context, when a new word is encountered, we can still position it in the word embedding space next to other words that occur in similar contexts. And moreover, the most recent methods generate embeddings at the subword level. So we can also reconstruct a word, the meaning of a word from its subwords. So if we now go back to traditional NLP, apart from mapping words onto semantic representation space, we also needed an explicit representation of relationships between them. So in this example, we can see how the information from the given sentence has been structured into tuples and predefined slots. And such representation has got its advantages over the original text representation. It makes it easier to search for complex information, for example, to search by type or in the context of complex relationships. So for example, imagine recruiting patients for a clinical trial and one inclusion criterion being the use of aspirin specifically to prevent myocardial infarction. So even though it sounds simple to us, searching for such information using simple keyword search is not likely to focus on relevant cases. However, now that we can represent words using vectors, it becomes very easy to process text using neural networks. And they, by their nature, encode relationships by learning ways that represent the strength of the connection between units of the network. And this means that now we can operate directly on the original text representation. And the nonlinear nature of neural networks means that they can be used to solve a variety of complex NLP problems. And one such task is question answering. Here you can see an example of using Google's BERT model to implement reading comprehension-based question answering, where the answer to every question is a segment from the corresponding text. And it's easy to imagine applications of question answering in healthcare. For example, it could make it easy for GPs to locate relevant information in medical records. Or, for example, it can be used to find evidence for inclusion or exclusion criteria when recruiting patients for clinical trials. So now implementing neural networks may seem daunting, and despite their complexities, they have actually lower barriers to entry for those who want to implement NLP solutions. So for example, the BERT model already encodes a lot of necessary complex processing, and it can be easily fine-tuned to perform specific NLP tasks. And the fact that the model itself has been trained on an enormously large data set means that fine-tuning does not require as much data. And here you can see how we fine-tuned the BERT model to identify serious adverse events. And this only required finding suitable problem representation, which you can see at the top as a row of yellow cells, and modifying the output of the network, which you can see at the bottom. And we were able to fine-tune the model using less than 300 reports. So what are the lessons learned from this use case? So, well, the advantages of fine-tuning existing language models include less time needed for development, less data needed for training, yet with less development time and less data, we can achieve better performance than traditional NLP approaches. And the impact this new approach to clinical NLP may have is increasing the overall efficiency of the healthcare system. And with that, we can improve health outcomes. And I'll just finish by putting this into the context of responsible AI. So we saw that we could use small data sets to develop high-performing text mining models. Small data sets in clinical text mining are the norm due to privacy concerns. So it's reassuring to see the small data sets are not necessarily a limiting factor when it comes to performance. And high performance is a cornerstone of reliability and safety. And there are other principles of responsible AI, but I will leave these for another talk. In the meantime, I'll thank you for listening.
Great, thanks, Irena, for an interesting, dive into text analysis and some examples there. So I'm just going to pass back now to Colin, who's going to introduce our final speaker. So Colin.
Yeah, thanks very much, Paul. So that's been a great start with the overview from Tom, and then the an application from Irena. So our next speaker is Bruce Guthrie, who's Professor of General Practice at the University of Edinburgh, who has a particular interest in multimorbidity and was chair of the guideline development group of the NICE multimorbidity clinical guideline that was published in late 2016. He's had significant funding in the area of AI and machine learning, and is going to share his experience coming from it as a clinician, maybe rather than as a mathematician. Over to you, Bruce.
Thank you. Okay, so thanks. So I'm going to talk about multimorbidity, and I'm not really going to talk about the methods too much. I'm going to talk about the context and why we chose to go down this route. And so the wider context is multimorbidity, people having multiple conditions. So one reason that these other methods are attractive is because multimorbidity is very complicated. It's very, very heterogeneous, and so we'd all recognise that someone who's got metastatic cancer and dementia is rather different from someone who's got hay fever and eczema, for example. But that heterogeneity makes it difficult to understand. I mean, this is fairly old data. This is for 1.75 million people in Scotland, and what it shows is if you have a row condition, then what percentage of people have got a column condition? And so we've kind of used this to think about common pairs. And as an example there, it kind of doesn't really matter what you have in the rows. About 1 in 5 people have got depression. And so you might be a physical disease doctor, but actually you ought to be thinking about people's mental health, particularly in relation to mood, because if you have depression, your physical disease outcomes are worse. If you have physical disease, your depression outcomes are worse. But this, of course, is only looking at it in pairwise ways. And so there's been growing interest and quite a lot of money, funding money put into clusters. And so clusters may be quite complex. This is someone with 5 conditions. Depends how you measure them. So the 2 kind of rows you see there, eczema, epilepsy, MI, type 2 diabetes, lung cancer. If you look at that in cross-section, these 2 people are the same, but they have a very different sequences by which they acquire their morbidities. And so there may be information in the sequence beyond what you see in the cross-section. It's also true that there's very heterogeneous outcomes. So if you're thinking about how you might cluster those conditions, you could do so in an unsupervised way, just what goes together. You could do it in a more supervised way where you're using outcomes like mortality or quality of life outcomes to look for clusters which have most impact on outcomes that you're interested in. But of course, they may not be the same. Depression rarely kills you, but it may have much more effect on quality of life than heart disease, which might kill you, but where you might be asymptomatic. And in my world, we're particularly interested in serious adverse outcomes, so the so-called geriatric syndromes. And so when I say this is heterogeneous, I mean, in our original data, in that 1.75 million people, there are 80,000 people with coronary heart disease. We're counting 39 other conditions, and those 80,000 people have 4,500 different ways of having those conditions. And that's cross-sectional heterogeneity. If you looked at the sequence in which they acquired those conditions, you would find even more heterogeneity. So the final issue with clusters is that from our point of view, of course, there's more going on than clustering of conditions in individuals. We're also interested in clustering by geography. Social determinants of health make particular kinds of morbidity cluster together, and then clustering in different settings. So how would you use ideas of clusters clinically? So we've got several bits of work involving working with people from informatics. But personally, I think, I mean, as already been said, I mean, the term AI is fundamentally unhelpful. Machine learning is also pretty unhelpful. It is a bit like saying medicine, but there's a big difference between an orthopedic surgeon and a psychiatrist, depending on the problem you have. And so it's more thinking about, well, there's a whole world of methods out there, and you need to find someone from the discipline to work with to work out what the right match between method and problem is. So in our NIHR grants in this field, we're looking at clustering and morbidities in individuals, and that's quite complicated. Most clustering approaches are clustered individuals. So depending on what you have, you're put in a cluster. But actually, biologically, it's much more likely that you should cluster conditions. There are groups of conditions that go together, and I, as an individual, can experience none, 1, 2, 3, or 4 of those clusters. And so we've got work in clustering, largely unsupervised clustering. So what do we observe there that is beyond chance? Because most clustering is chance, or most combinations of conditions is chance. And we'll then go looking to see whether we can find any genetic evidence, any evidence in genetic associations that these clusters have a biological basis. And so that's kind of very much focused on etiology. We're also going to look at clustering and morbidity in households and neighborhoods. That's more a social determinants of health and public health perspective. And then clustering in clinical context is largely about, can we predict adverse outcomes? Can we predict in the community and at the hospital front door who's likely to have bad outcomes of various kinds? And alongside that, because this is never all just about AI, well, what kind of models of care might you develop for people in different groups? And so in terms of the methods used, one of the joys of working with people from different disciplines is they just look at the problem in a different way to you. And so coming from an epidemiological perspective, we might have looked at clustering morbidities in individuals in one way. My informatics colleagues just had a beautiful way of thinking about it that meant we could do more than I could have imagined. So we're interested in looking at multiple clustering methods in multiple data sets. The multiple methods issue is, well, you know, are your cluster solutions consistent? Because if they're not consistent across methods, you might be suspicious they're not real. Multiple data sets, do they replicate across data sets? We're largely focusing on the cross-sectional because it's more tractable, but we will look at some longitudinal clustering as well. We're interested in clustering of morbidity clusters in households and neighborhoods. So people who live together share many lifestyle factors, and people who live in neighborhoods share a bunch of social determinants of health. So that's got a mix of things. So one is using natural language processing to enhance neighborhood data. So it's pretty easy to say that you've got green space near your house. But of course, if you perceive that green space to be dangerous, you won't use it. So this is using social media data and local print media data to try and understand perceptions of neighborhoods over and above physical characteristics. And that's using a mix of methods from my world, so multi-level modeling to do the analysis, and then more machine learning approaches. In clustering clinical context, again, has natural language processing. So many of the things that I'm interested in as outcomes in later life are not well coded. So falling, bleeding, delirium, incontinence, not coded at all well, but are often in free text. So can we extract information from free text to better understand outcomes? And we're interested in, can we predict or can we identify people at higher risk of those outcomes? And that includes both biostatistical approaches, and then in this particular case, using knowledge graphs. We're kind of agnostic as to which is better. Which is better in this case is which one predicts best and is usable and is transparent. And then across all the methods, we're using something called multi-layer networks, which is an expanded type of knowledge graph. And so comparing methods is very important to us. Explainability is very important because black box prediction methods may not be attractive to clinicians. They may not be trusted. And so if something isn't used, it doesn't matter if it's technically a better predictor, if it's not actually functional. And that's all I was going to say. Thank you.
So thank you very much, Bruce. So now I'm just inviting people. Paul and I will be keeping an eye on the chat for questions that have come in. But I'm going to kick off by some questions that have already come in beforehand, and also picking up on those great and incredibly kept well to time talks from our experts on a complex subject. Maybe I'm going to pick up with Bruce first of all, which is to say, we've had questions about, is it ready for the clinical setting? What a good application. So if I start with you by saying, can you give an example of something in your world where machine learning has made a difference with something that you wouldn't have expected and has actually moved you on? Or perhaps related to that, in the things you've been discussing, what would you most like to get out of this? What would you think, wow, that's really great. That's really moved us on.
I'm not sure that machine learning has done anything in my world that I've noticed. So that's not to say it's not doing stuff behind the scenes on my phone and whatnot, but in my clinical and research world, I haven't seen any applications that really make huge differences. I've seen applications in other bits of medicine that I think are relevant. So some of the natural language processing, I think, yes, that could be incredibly useful, but it hasn't made it into my world yet. I mean, as an example, though, if you want to do natural language processing of GP records, GP free text is much more like a tweet. Hospital free text in terms of letters written is kind of much larger, much more expanded. I mean, there may be difficulties. In terms of prediction, I'm not aware that machine learning has ever been shown to be better at predicting outcomes for the kind of tools that I use. There's been one explicit comparison that I've seen, which is cardiovascular risk prediction, where nothing outperforms the standard method. They're all actually very similar. And the standard method is at least transparent.
All right, but to turn around a little bit, you're working on the areas you just described. What would be a great outcome for you? What would you think, that's what I really wanted to know, and I'm really surprised that I can do this now. I didn't think I could.
Two things, and so this isn't necessarily what we're working on. So as I type, it might be interesting if NLP was able to either support me in coding. So SNOMED's a complete nightmare, it's too complex to code. In reality, we use hardly any codes. We've got these enormously elaborated coding systems, which none of us use. They're just completely useless. We all stick to the same 5 codes for a condition. And so NLP that actually helps me code in more granular way would be very interesting, would have to run live. And secondly, our ability to predict outcomes is actually not very good. I mean, it's okay, but we can put people in broad groups when trying to predict who's at highest risk of bad outcomes. And it would be nicer to be able to get something that was more individual, more accurate at individual level. And I would love that to be possible.
Okay, I'm just going to take the opportunity actually here, if you don't mind, Paul, just to ask Irena to come in here. So there's Bruce has put a wish list up there of saying, can he type in and it codes virtually in real time? Do you think is that a realistic prospect? Is that something that can be done?
Yes, that's feasible. Of course, we would need a lot of training data to train that to work possible. But you know, there are interesting things, you know, that a lot of things that are, you know, one of the bottlenecks is data annotation. So who's going to annotate that? But I think we are missing an opportunity to do that as we go along. So I think we need to train the systems, you know, have something crude, and then have clinicians curate as they type, you know, and with time, you know, the systems will become more accurate. And I think we need to embed these things, you know, even with images. I think we are missing an opportunity to just track eyes, you know, once a radiologist is writing a report. I think it's very useful when they zoom in and then describe something. That can act as a good training data set, you know, to fuse, to basically interpret images, to generate reports automatically, you know, all of these things. I think we need to bring technology into the NHS with future in mind, you know, not necessarily we want a system that works now, but start collecting the data, especially annotated data, as an investment into building these models.
And I think that response might bring Tom in here, but it's quite sort of questions that have come up, which is asking, I'd capture it this way, is what is the role of the physician in this game? So some of them are saying, can I train in AI? Some of them are saying, how do we train in AI? What do we need to know? But I think I would turn it around this other way of saying, well, maybe you don't need to, but in the way that Irena's describing, you could learn to use it and annotate it and help with processing. I don't know if, Tom, you want to maybe pick up that question about how do you see the role of healthcare workers, maybe not, I say researchers, but certainly healthcare workers in this technology?
So 2 things to say. The first is we do train medics in AI at Exeter, and we do that through an NIHR applied research collaboration initiative. So it does attract medics. So we have quite a few GPs involved in now building their own models, but we have a lot of NHS analysts as well who we're very hardly trying to upskill them to have these sort of machine learning skills. So for me, so I think I'll just be blunt and say a lot of academics are quite naive about the way health services work and the way medicine works. And, you know, we turn up with our techniques that we've worked in kind of synthetic environments with that work very well. And we just find that the data, you know, electronic health records are very different beasts. And so for me, it's transferring some of these skills to the NHS in some small ways over a long time period is the way that we'll see machine learning actually start being used. I'm pretty skeptical about industry injecting machine learning into the NHS because we don't know how most of those models work. And we didn't really talk about it, but one of the big issues, and it's an issue in biostatistics as well, is, the provenance of data, the pre-processing of the data, the representativeness of that data, the selection biases within it cause all sorts of problems, not just in medicine, in criminal justice and everything else. So for me, I'll go back to that point. It's about transferring some of the skills from industry and from academia into the health service itself, and having the, both medics and analysts within the NHS who have the skills to start building some of these models. And I think, like Irena mentioned, that it doesn't need to be complicated. It doesn't need to be super sexy stuff to start off with. It can be simple applications that and move away from this idea of automation, move away of, towards the idea of these systems assist medics with the jobs they have to do and increase efficiency of it. Coding is a really good example of, that, from what you described, Bruce, that is not something I'd enjoy doing. That's a good example of where you could introduce some of these things. And I think it's within the realms of NHS analysts to learn these skills with support from medics.
And I guess the bit that I think Irena was, to me, hinting at is that when it generates an output, it's important that the clinicians look at it and say, but that wasn't what I meant.
Yeah,
that's the engagement with that process. They may not understand what's going on in the background, but they can comment on the output and refine the output.
Also putting human in the loop, and I think it's worth stressing, we are not replacing humans, we are basically extending their brains, making them more efficient, rather than doing the same thing that they are doing. We just want to make what they do easier and more efficient.
I think so. Another example in precision medicine is, when I talked about benign and malignant tumours, that's not really an issue for people to diagnose. It's everything in between. So, a machine learning tool that can flag up, it might be a bit more sensitive than a clinician, but not as specific, may flag up these are potential cases that you need to look at. I think that sort of thing is much more useful than any sort of automated screening program.
Yeah, and I think that it's an interesting area, is actually to help people concentrate and get rid of the noise. An issue I often think about is this issue of rare diseases, particularly in general practice. How are they ever going to realize that this adds up to a rare disease and not a common disease? Because, what you'd want is something that pops up and says, have you thought about Gittelman syndrome here? And the answer is no, but if I look it up, I'll know what it is straight away. So it helps kind of focus clinicians maybe on possibilities, but doesn't necessarily take the decisions for them.
Of course, there was a very high profile attempt to build a diagnosis machine. Yes. It was IBM Watson. And that is, it really struggled. It did do a few interesting things, but overall it didn't work. And that, I think, comes down to my original point about how narrow the intelligence is. So having tools for specific tasks that at the moment, I would say for now, are the ones that are much more likely to succeed than these all singing, all dancing AIs.
Paul, do you want to talk about some of these issues?
There's a question just come in, but it's just building on that, Tom. And there's some questions in the that we had previously about getting into this topic as a whole, and people asking, is there particular software and training and so on. So how do interested people, you said you taught Exeter these kind of skills to clinicians, but how do people get in as a kind of entry into this whole topic?
Good question. So, there's many good free courses that can give you an overview of machine learning online. So, I think Udacity, for example, may provide free courses from possibly Cornell or MIT. I forget now. Exeter each year runs its Health Service Modelling Associates program. And that's a very technical program where we take people from kind of very, very minimal skills all the way up to building fairly basic models themselves. And then we mentor them on their own project over a year. But so I think I'm not sure is the perfect answer. I'm not sure. Bruce he's got his hand up. Maybe he can say something.
Well, I don't have a perfect answer, but I mean, I sit on the Wellcome postdoctoral clinical fellowship panel. And so we do see a number of applications which come in, which kind of use machine learning as a kind of sprinkling of fairy dust. And so I think you've got a choice. You've always got a choice. Are you going to be someone who learns how to do it yourself? Or are you going to be someone who brings a skill set to a team? And so, of course, when you're in early career doing a PhD or a postdoctoral fellowship, you can choose to learn it for yourself. If you're not in that position, you're never going to learn to do it for yourself. I mean, I'm never going to go and sit down and do a machine learning MSc and then PhD. And so the question is, what do you bring to the team? So I bring epidemiology, and I bring some mixed methods health services research. And so epidemiology brings a way of thinking about cohort building, which is not present on the informatics side because they don't actually need to think about it. I mean, they're perfectly capable of thinking about it in the same way I'm perfectly capable about thinking about their method, but it's the team that counts. So I think if you're a late career researcher, you need to find someone from the field who has the right kind of methods for your kind of problems, and you need to work with them. If you're an early career researcher, you could choose to make it your speciality. But of course, if you did that, you're not doing epidemiology. There's only so much time in the world. And so there's choices. You have to choose what you're going to be really good at, and then you have to make sure you have enough interdisciplinary experience and desire that you then go and find the right team, because it's almost always going to be a team sport.
Also had some questions on the topic of kind of using AI and machine learning in real-time settings. There's one come in just now in the chat, also previous questions around that. So, I mean, the question is around research data indicating the potential utility of AI in predicting serious adverse events and outcomes in a hospital setting. So more like kind of real-time, as in running in the background. So do the panel think that that future is possible in using these methods in real-time settings?
Yeah, I mean, so certainly the tools that we're thinking about, the tools that we want to develop in our AI multimorbidity grant are intended to be used in real time. You're at the hospital front door, you know things about the person from their previous record, and you also ideally know some things about why they're there then, based on either free text you put in or based on coded data that you put in during the assessment. And it only works if it's in real time, because the decision you're trying to decide is, does this person go down this care pathway or that care pathway? And so do you go down a bog standard hip fracture care pathway, or do you need to go to something more complex, would be the question. The AKI one's quite interesting, because I mean, I'm not aware that anyone knows. I mean, I presume this is the kind of royal free Google deep learning kind of thing. I'm not aware that anyone actually knows how that works or how good it is. So just because you can implement a tool that gives you, you're at high risk of AKI, without really knowing what's under the bonnet or its predicted performance, why on earth would you want to implement it? And actually predicting AKI, I don't think it doesn't strike me as the hardest clinical problem you could address here. Risk of AKI, you're vomiting, you've got CKD, you're on an non-steroidal.
If I can come into that discussion. So I think what the real-time bit is, things are changing, more data is coming in. People don't use the background data. To me, the classic example of this is the news score that everyone has thrust at them, which doesn't actually think about whether it's incorporating saturations, incorporating blood pressure, pulse, and so on. But it's not using any of those in a particular direction. And of course, it can tell you that sepsis is developing if it's plotted in real time and brings in the prior information that this is likely to be sepsis, the rising CRP, the increased lab data. All of that will help you make the decision much more quickly than going, oh my God, that seems to have gone badly. So I think that kind of real-time computation does certainly make sense to me on a pragmatic basis.
We've also had some questions again in advance around the topic of ethics, which is a tricky one. And again, we've been talking now about real-time decision making or in different ways. But I mean, in terms of where does responsibility lie? If we're going to be, moving to more advanced AI and for decision making, does the responsibility lie with the clinician or the machine? Or I mean, does anybody? I mean, Irena, you picked up some ethical issues on your work as well. And Tom as well, in terms of some of the work. Do you want to comment about ethics? Who wants to go? Irena?
Yes, so absolutely. Any research, but in particular in healthcare, it's just difficult to comment, like in current circumstances on ethics. So, yeah. Sorry, I'll go to my slide and then just try to have it more structured. Sorry. Yes, so first of all, privacy and security. I'm gonna give a talk next week on de-identification. So this is something where AI can help because now we can de-identify quickly. And if you want to explore, different NLP approaches, that is actually possible. NLP enables NLP research because we can use NLP to de-identify, data sets on a large scale. So that's one of the, first bottlenecks in NLP in healthcare, because we always have small data sets. We also have data sets from a single institution. And the data sets, then methods are not portable across institutions. So we can't trust these methods. So that's one thing where NLP can help. NLP is more sensitive to that than, for example, image processing. But I think AI can help, to de-identify, and then we can develop our models. The second issue is transparency. And we have two issues here. One is interpretability, another one is explainability. We need to be careful. The complex models tend to perform better, but they get more obscure. But can we interpret the findings? I like to use one example is using electricity. We don't need to know how it's generated, as long as we know that we need to plug it in. And how to use, so we can get confidence that actually we can use electricity safely. We can use AI safely, but we need to ensure that indeed is a case. Inclusiveness in NLP. Think, for example, about chatbots. Chatbots can improve efficiency of healthcare systems, especially now that we are accessing NHS remotely. But is it inclusive? How does it apply to people whose native language is not English? How does it apply to these, that are not health literate or computationally literate? People with disabilities, some can't see, some can't speak, etc. I think I touched upon reliability and safety, and yes, we can build, highly accurate models these days. Accountability. I think that's important, but that needs to be decided, at the level of policy. Who is accountable, if a system does go wrong, which is a possibility, and how do you manage that risk? So that's my thoughts on responsible AI and ethics.
I think there you've actually picked up another question that came up in the text, which is saying, you've trained NLP, natural language processing, on a particular individual. What about multiple individuals? We didn't get as far as people whose first language isn't English and so on. So I think that was very good. There was another question for you, actually, Irena. Used eye-catching selection of icons rather than words. Was that a deliberate decision, given your work on text mining? Do you want to comment on that?
It was deliberate, but not given my work on text mining. I just prefer people to focus on what because people tend to read and then they stop listening. So I use it just to guide the listener and make like specific point rather than them reading it mechanically.
Bruce, yeah.
So I mean, coming back on the ethics point, so one of the questions is, if you have a prediction algorithm, to what extent does it then drive care? I mean, I think my take on that would be that in their current state, any AI or any machine learning based prediction algorithm is going to function the same way that any other risk prediction tool does, which is that by and large it does not determine care. So there are some prediction tools which are used pretty deterministically. So DVT risk prediction kind of puts you in categories, and the clinicians rarely step away from that. I think if you're trying to predict who's likely to have a fall in hospital, you're probably much more likely to be thinking about it in terms of we want you to stop and think, So it's a prompt to clinical judgment. It's not a deterministic, yes, you go that way, you go that way, you go that way. It's you go that way unless, but you might want to stop and think about this person.
Yeah, and I would certainly see it that way as innate decision making. If you take the example of, you know, sat nav apps, if you like, they'll tell you what they think is the shortest journey. You don't have to go that way. You're driving the car. You decide which way you want to go. But every time I've done that, it's taken longer than I thought it was going to. I now actually believe that technology, and I'll go with it, even if it looks stupid in the first case. But you're monitoring it all the time. So I think, to me, the ethics issue is that the decision remains with the clinician, but they've got a much better way of putting all that information together. And I think you gave the example of falls, but for me, for example, the question of who needs a CT scan or who needs a CAT scan now, it's a big argument between us and the radiologists half the time, but on what basis? And in fact, we could make that decision on much firmer basis if we put all the data together in a reliable and robust way, it seemed to me. But it's a decision tool.
Yeah, but as a clinician, you have information the algorithm doesn't. You're standing looking at them and thinking, this person's really sick. You know, what, irrespective of the measurements and the other stuff. And so you wouldn't ever want to let the radiologist say that you need a score above X to get a CT scan now. You need a score above X, or the clinician can say this person needs a CT scan.
Well, in a way, I want to just bring that in to the last part of the discussion, which is that, you know, what are the common pitfalls in this methodology? And Bruce says, you have information that the algorithm doesn't have. Why does it not have that algorithm? It can look as well. There are cameras as well. It can capture what we think is a sick person. And we're not that good necessarily at knowing what a sick person is, because we didn't know what they looked like before. But if there's images from what they looked like before, you know, like looking at 2 chest x-rays before and afterwards. So I'm going to throw that back now to the other members of the panel. What do you think are the commonest pitfalls? I'm suggesting that it's lack of data, but what are the common pitfalls in the use of this methodology?
I mean, I can start with perhaps you know, selection bias within your data, or the provenance of your data not being well understood. I thought Bruce's point was really great about, you know, if you're an early career researcher, late career researcher, the best way to sort of get involved, and that can handle some of these thorny issues, because, you know, machine learners don't really understand. They're not trained in epidemiology. They're not trained in, you know, biostatistics. So they perhaps a bit naive about some of the biases within the data. And, you know, I always think that, you know, there's nearly always bias in society that finds its way into our data, either just normally or by some sort of weird way we've collected the data, but it takes machine learning to scale that. So we always try and embed, you know, some practices within our studies to try and get to grips with that bias first. And after we've built the model, you know, you know, what are the outcomes for different groups within the model? That's for me. I actually wrote down what I thought the top 5 issues were, and that was top of my list. And but I think medicine's in a good place to deal with that, more so than other areas that don't have the strong discipline of biostatistics built into it.
Right. Paul, do you want to have some last words here, and I'll wrap up? How have you viewed the discussion today?
Yeah, no, really interesting. I think even going back to the very first presentation by Tom, I think the terminology is not helpful, and Bruce has also mentioned that. So don't be put off, I think. Think of it as a scary, very scary set. I mean, AI or machine, whatever you want to call it, it's just, you know, how best we use our data in a more constructive way, in a more informative way, to help make predictions. And it's not to replace that clinician decision making, as you say, it's to guide that decision making, to support that. And with the wealth of data we have, it'd be foolish not to be using that. And that can be, you know, in terms of either for strategic planning purposes or for real-time decision making and so forth. I mean, Tom and I are also particularly interested in, you know, so if you can do the predictions, then so what next? How does that impact on the way in which the services are delivered? And does that have an impact on, you know, capacity or the kind of efficiency of systems? And so there is a whole other another webinar we could do on, analytics and actually modeling capacity decision making and so on. So if you can, for example, look at clinical pathways and decide on what might be the optimal route through a pathway to reduce time to diagnosis, for example, then of course it has implications immediately in terms of resources and the way in which you do that. So that's really fascinating to me as well in terms of the interface between predictive methods and so forth. But yeah, so I think there's a huge huge opportunity.
Yes. Thank you. And I think the key of what we've heard today is we need to speak each other's language to get the best of that opportunity. If you're afraid of self-driving cars, you need to understand how they work and then understand what the risks are. And I think the same is in this area, to harness the true potential of this. I think it's one of the reasons it hasn't moved forward is that people have found it difficult to understand. So I would say get involved and find out more at every level that you can and make the best use of this technology. Thanks to everybody for your contributions today. We hope this conversation will continue, and do also let us know if you want other subjects, this or other subjects discussed in AOP webinars. We'll be very keen to host them. Thank you to everyone.